Hello, my name is Michael Rubeiz. I am a fourth-year medical student at the University of Cincinnati College of Medicine going into internal medicine. Today, I would like to present a case describing a rare source of dysphagia in an older man. Oropharyngeal dysphagia in the elderly should be promptly evaluated and is generally due to a structural abnormality in the esophagus with the potential for malignancy, or often is the first sign of a serious neurological disorder. Uncommonly considered are sources of extrinsic compression, which can also lead to devastating outcomes. A 71-year-old male with a history of pulmonary embolism, heart failure, pulmonary hypertension, and cervical osteophytes presented to us with 2 months of progressively worsening difficulty swallowing solids and liquids, as well as some mild constant chest pain. Initial workup did not reveal any acute cardiopulmonary abnormalities, including serial troponins, ECG, chest X-ray, and CT angiogram of the chest. A modified barium swallow was then performed, which showed severe aspiration with all food consistencies, and given his history of cervical osteophytes, it was postulated that these were compressing the esophagus, leading to his symptomatology. As a result, the patient was then referred to neurosurgery with the goal of osteophyte resection. However, upon a preoperative review of his prior imaging, specifically the CT angiogram of the chest, as well as the modified barium swallow, an aberrant right subclavian artery, or ARSA for short, was identified, which was likely compressing his esophagus, causing his symptoms. This is visible in figures 2 and 3, where an ARSA is shown in sagittal, coronal, and transverse cuts of the CT scan, running behind the esophagus and vertebral bodies. An ARSA is the most common congenital abnormality of the aortic arch, with an incidence of 0.5 to 1%. Illustrated in figure 1, it arises as the last branch of the aortic arch, rather than as a branch of the brachiocephalic trunk, and in 80% of patients, it crosses the midline between the esophagus and vertebrae, running a risk of esophageal compression should it grow in size or become aneurysmatic. The majority of ARSA are asymptomatic. However, when symptoms are present, they include dysphagia in about 71% of patients, and less commonly, shortness of breath, chest pain, and cough. As a result, the patient's surgery was canceled, and he underwent inpatient speech rehabilitation and was eventually discharged with outpatient speech therapy as his diet was advanced and his symptoms improved. The identification of an ARSA is necessary to differentiate from other causes of dysphagia, as the development of symptoms can indicate that an ARSA has become aneurysmatic, which can lead to rupture, dissection, compression of neighboring structures, and arterial thrombi due to turbulent blood flow. Given this patient's past medical history, older age, and the size of the ARSA not exceeding surgical threshold, surgery was not indicated. By identifying this patient's ARSA, we were able to prevent a high risk and likely futile resection of his cervical osteophytes. In conclusion, it is important to consider sources of extrinsic compression when working up oropharyngeal dysphagia in the elderly, and to identify an ARSA to prevent poor outcomes in patients who develop an aneurysmatic ARSA. Future directions of this product include studying the efficacy of speech rehabilitation therapy in oropharyngeal dysphagia due to ARSA with long-term follow-up, as well as identifying specific thresholds in which cardiovascular intervention is clinically necessary. Thank you very much.